හම්බුණානේ මේක නේද?
ඔව් සර් හම්බුණා.
හරි. Right. විභාගය 20ද පටන් ගන්නේ?
20 සර්.
Right. So up to now we have finished cardiovascular, respiratory, nephro, gastro, hepatology. ඒක ඉවර කරානේ.
ඔව්.
හරි. Okay. Right. Right. So today let's start on endocrinology. Right. This is paper 1. ඔක්කොම කරන්න අමාරු වෙයි අද. We will do as much as we can. Right. Because I have to go for a meeting at about 1.5 hours time. But yeah. But we will do as much as we can today. හරි. Hi. So the first few questions in this paper are on the pituitary gland, right? Now this is not something that we've touched upon in the clinical appointments as well, because these are very rare conditions, very specialist conditions. But of course, MCQ, you can get a few of these concepts popping up, right? Now the first thing is hypopituitarism, right? Now generally we divide all the causes of hypopituitarism into two groups. Right? Hypopituitarism can be due to patients who have tumors or mass lesions in the pituitary gland, right? And also there can be other causes of hypopituitarism without mass lesions, right? For example, the very famous Sheehan syndrome, right? There is a sort of infarct of the pituitary gland. Or there are various other disorders, as you can see in this table that I have given you, which are there are infiltrative diseases into the pituitary, right? And they are very exotic and rare, right? So things like sarcoidosis, which cause pituitary infiltration, or granulomata in the pituitary, right? Hi. But I've told you the trick about these causes, true or false regarding the causes, all of those are correct, right? Something will cause hypopituitarism, right? So, but for your reference, just glance through this list and you will have all the answers given there. Right, so that all is true. Right, now if you take the clinical features of hypopituitarism, they are obviously due to the hormone deficiency, the individual hormone deficiencies, right? And actually the initial manifestations are due to growth and sex hormone deficiencies. That is what you initially observe, right? And of course, if the tumor is big enough, it can cause mass effects, right? And when we're doing neurology, we talked about things like bitemporal hemianopia, due to pituitary tumors. And also, in the pituitary is big enough, it can encroach on the cavernous sinuses on either side and cause cavernous sinus lesions as well, right? So there might be a certain set of symptoms and signs due to mass effects of the tumor. Right. Okay. So question number 2 is sort of focusing a little bit on the clinical manifestations and management. Right. So as I told you, in a patient with panhypopituitarism, the initial manifestations are actually due to sex hormone and growth hormone deficiency, right? And they usually, in a patient with panhypopituitarism, these are the ones that manifest first, right? Adrenal, thyroid, they tend to come on a bit later on in the disease course. Okay. Now, another important thing is posterior pituitary hormones, right? So another important concept here about hypopituitarism or panhypopituitarism is that they are mainly present with deficiencies of anterior pituitary hormones, right? As you can see in this list. Now, as you know, the posterior pituitary produces vasopressin. And the problem there is that if you know, because of posterior pituitary insufficiency, they would get diabetes insipidus. But they don't usually manifest diabetes insipidus because when their anterior pituitary hormone, the ACTH axis is deficient, it sort of counterbalance, right? because it is the opposite, right? So it counterbalances the tendency to develop diabetes insipidus. So they don't usually have manifestations of diabetes insipidus at all. But sometimes when you start treating the adrenal insufficiency with steroid replacement, then this can unmask the diabetes insipidus. So that is something that you need to remember as well about the symptoms of pituitary insufficiency. So in the early stages, they will have anterior pituitary hormone deficiencies, and the ACTH adrenal insufficiency sort of masks off the posterior pituitary problems like diabetes insipidus. Right? The ADH deficiency is sort of masked off, right? Because of the adrenal insufficiency. But sometimes when you start treating the adrenal insufficiency, this can sort of unmask the DI. And that is, I think, asked in one of the MCQ statements here, which is the third one, right? Oh, sorry, third one, fourth one, right? That is true. Right. Now, obviously, in hypopituitarism, right, in order to diagnose it, you need to test for individual hormones, right? You need to test for individual hormones. Once you establish the hormone deficiency profile, then we also do imaging to confirm whether there is something in the pituitary gland, like a tumor, for example. Right. Now, again, this is a bit too much for you, but the tests that you use, most of them, you can directly measure the hormone, but some of them you need to give certain stimulatory challenges to the pituitary gland, right? And see if that stimulatory challenge can push the pituitary gland to produce hormones, right? But some you can directly measure, right? For example, LH, FSH, whatever, you can directly measure. Thyroid profile, you can directly measure. And we'll talk about the findings on the thyroid profile later on in MCQs, right? But for something like growth hormone or ACTH, right, you need to do stimulatory challenges, right? You stimulate the axis to see if it produces growth hormone or ACTH, right? Right. So for growth hormone, use the insulin tolerance test because that drops the blood sugar and stimulates the growth hormone secretion, right? If the pituitary gland is not working, it does not increase growth hormone in response to the insulin. So you're using a stimulatory stress, right, through the pituitary gland to see if you can get any of these hormones to be secreted, right? Right. So, yeah. Hi. Right. Any questions up to now? Right. And the management of pituitary insufficiency is to give replacement, right? Replacement hormone therapy. And there is a very famous point that all of you should know by now, right? That this replacement of steroid and thyroxine business, that is very important, right? So essentially what you should do is, and I've written this here, right? Both steroid and thyroid hormones are essential. They are essential. So whatever you replace, you have to replace the two things, right? And make sure you have adequate steroid cover, steroid replacement cover, and that is usually with hydrocortisone before you start the thyroxine, right? So very important thing, panhypopituitarism, the treatment is very simple. You have to replace the hormones. Of this, the essential hormones are the steroid and thyroid hormones. They are essential. But when you're replacing these, make sure that you give them a nice steroid hormone cover with hydrocortisone, establish them on that therapy, and then start the thyroxine. The reason for that, Lamai, is that when you give the thyroxine, it increases the basal metabolic rate, right? The metabolism, your activity starts getting increased, right? It increases your basal metabolic rate. And that is a stress, right? When you increase your basal metabolic rate, that is a stressful situation to the body. So you have to have that steroid to cover that. That's then they get an adrenal crisis, right? So it's very important that you establish them on steroid therapy, make sure they're happy on that, and then add on the thyroid hormone replacement later, right? So that they don't get stressed out when the basal metabolic rate increases and you have the steroids to cover that stress, right? That's the lady. So that is an MCQ point, and of course an important thing when you're doing this management. So thyroid hormone replacement is essential for life. It is an essential hormone, and steroid hormone replacement should precede thyroxine replacement, right? Now the other things are all optional, right? For example, growth hormone replacement is optional, right? But it can improve quality of life in patients with panhypopituitarism, and is important in certain things like improving body composition, reversal of lipid abnormalities, it can play a part. But it is not essential, right? It is an optional replacement. Now also remember that androgen replacement or estrogen replacement itself will not give the person fertility. Ne? If you think of it and you have done GNOBs, fertility enne naha. Right? That is an important concept. It will just help develop the secondary sexual characteristics for these people. Of course, if you want to establish fertility, then it is a bit more complicated. You have to go for a GnRH pulses and HCG axis. You have to replace the whole axis if you want them to establish their fertility. Right? Again, not commonly done, and you need very specialist endocrinology input for that. Right? If you just give the androgens and the estrogen, that will just help in developing their secondary sexual characteristics. Right? But if you want fertility, you have to give pulsatile GnRH and HCG for that purpose. So the last statement here, true or false again, hypopituitarism, androgen replacement in a male restores fertility. It cannot restore fertility. It can establish secondary sexual characteristics only. If you want replacement of fertility, then you will have to go for this pulsatile GnRH right from the top, and then it's very challenging. Right? So there are multiple hormone axes that you have to replace to establish fertility, but it can be done. And you need very specialist endocrinology input for this. So these are some concepts about hypopituitarism, right? Any questions? So causes api kata kara. Clinical manifestation, remember, it's usually growth hormone, sex hormone deficiency that manifests initially, right? And then diagnosis, you can measure the hormones directly. Certain hormones require stress tests to see if they actually elevated. In panhypopituitarism, even if you stress the pituitary, it still won't produce any of hormones. For example, growth hormone, you need to stress it out by giving insulin tolerance test, right? ACTH stress karanna pula when you give an insulin tolerance test. So your idea is try to see if you can push the gland to see if it produces anything, right? In panhypopituitarism, it won't. However much you stress the gland, it won't produce anything, right? And then management is it hormone replacements. Steroid and thyroxine are the essential ones, and there is a particular way in which you replace them as well, which we have discussed. Any questions, Lamai? Again?
Sir, you mentioned about this in hypothyroidism, when they go into this, say, myxedema coma, do we check to see if their ACTH is also low? Prophylactically,
we give them steroids. When they are in myxedema coma, we give them steroids usually. And there are many uses of that, but you can't be measuring the ACTH before giving the thyroxine because you won't get the investigations back in time. So empirically, we actually do give them steroids, and that helps indirectly for the thyroid thing as well. Yeah?
Yes. Okay. Thank you.
Prolactin you can measure directly, yes. Or with the TRH stimulation testing. Okay, right. Fine. Now, obviously, this picture is very familiar to you, acromegaly. You have seen this typical sort of morphology of acromegaly. Now, acromegaly is often, or say 99% of the time, due to a pituitary tumor, and often these tumors are macroadenomas, right? Often these are macroadenomas. Very, very, very rarely, you can get growth hormone secreting tumors in other parts of the body. For example, some retroperitoneal sarcomas can produce growth hormone, but that's very, very rare. almost always 99% of the time, acromegaly will be due to pituitary growth hormone secreting tumor. And again, I think about 60% of these tumors are macroadenomas. Another important thing is you can get concurrent prolactin secretion in some tumors, right? And also about the matakati, sometimes the tumor is big, it presses on the stalk, right? And then that can also increase prolactin because the stalk is dopamine, which inhibits prolactin secretion, right? So some of these tumors can themselves secrete prolactin, or sometimes they are big enough and cause stalk compression, which also increases prolactin, right? Now here I have given you a list of, this is very important, MCQ වලට නිතර අහන දේවල් unfortunately, right? Sort of the systemic complications of acromegaly. Right, so you need to know these. And we'll just go through this MCQ. I've put a few things here. Right. So acromegaly can cause proximal myopathy, right? But actually, a common manifestation is that because of the soft tissue enlargement, they get sort of entrapment neuropathies. Soft tissue enlargement on acromegaly, you have seen their hands. The soft tissue enlargement can press on and cause entrapment neuropathies, right? And this is, for example, you get carpal tunnel syndrome. It's very, very common in acromegaly. Sometimes a presenting feature, carpal tunnel syndrome, soft tissue enlargement, entrapment neuropathies. Right. So proximal myopathy, entrapment neuropathies are neurological manifestations. Right. In the gut, very important to remember that there is an increased risk of GI adenomas. So they get more adenomas, polyps in the gut, right? And these can sometimes manifest and develop into cancer. And patients with acromegaly, we usually offer them screening, right, with colonoscopies, right, for these polyps and cancer transformation. So high risk of colorectal cancer is true. Now, acromegaly has a lot of coronary and cardiac issues. They have an increased incidence of coronary artery disease, and also they can have cardiomyopathies, left LVH again because of this enlarged soft tissue business. So increased mortality is, yes, and actually we understand now, looking at long-term epidemiological studies, that the highest mortality is due to coronary artery disease. So patients with acromegaly, their mortality is mainly due to coronary artery disease. Apart from that, you can see there are various other things, right? When there is increased growth hormone, they get increased glucose in their bloodstream, right? And can cause diabetes in the pulwa, right? And you get other manifestations, very reproductive manifestations as well. Right. Now, how do you diagnose acromegaly? Acromegaly, the gold standard screening test is the IGF-1, right? So IGF-1 is the screening test, and that is usually elevated. Right? ඒක තමයි සාමාන්‍යයෙන් අපි කරන්නේ, right? And then the other thing to do is, right, once your IGF-1 is high, to confirm it, you have to assess their growth hormone level. හැබැයි මෙතන ප්‍රශ්නේ තමයි growth hormone එක කෙලින්ම මැනින එක අමාරු වැඩක්. It changes. Right? So here what we do is, අර pituitary එකේ කරපු එක අනිත් පැත්ත කරනවා. Their growth hormone is high. So now we try to suppress it, right? The basis of this test is, in a pathology, it won't suppress. It will be high, right? කොච්චර suppress කරන්න හැදුවත්, it won't get suppressed, right? So what we do is, we use the OGTT. අපි glucose දීලා බලනවා growth hormone එක suppress වෙනවද කියලා, right? In patients with acromegaly, the growth hormone is pathologically high and will not suppress, right? With glucose load එකක් දුන්නට, the growth hormone will not suppress. So the investigative sequence is, you do the IGF-1 as a screening test first in a patient with a supportive clinical history and examination. And then what you're trying to do is, you're trying to suppress the growth hormone with a challenge. You're trying to give a massive load of glucose, see if it suppresses, right? Samanya glucose දුන්නම growth hormone එක suppress වෙන්න ඕනේ, right? But it doesn't happen if there is a tumor, right? So OGTT is the other test that we use, and that is for confirmation. OGTT දීලා අපි බලනවා growth hormone level එක before and after, right? Now, management in acromegaly is usually surgical because it is a macroadenoma. It is most often surgical management, right? Treatment of choice is surgery. but sometimes you want to do some medical management to shrink the tumor beforehand. Or sometimes you use this octreotide as a adjunctive therapy, right? Our drugs pegvisomant that blocks the growth hormone receptor, right? And also dopamine agonists. All of these drugs are used sometimes before surgery when you want to sort of shrink the tumor. And then sometimes you also use radiotherapy to sort of shrink the tumor as well. So medical management, radiotherapy, but surgery is the treatment of choice, right? Most of the people will have surgery, but sometimes we give medication until the point of surgery or to shrink the tumor beforehand, and the examples are given here. Hiran me api OGTT එක කරනකොට growth hormone එක කොයි වෙලාවෙ බැලුවත් ප්‍රශ්නයක් නැහැ. So when you follow the OGTT protocol, that is okay. සාමාන්‍ය ඔක්කනේ fasting ඇවිල්ලා ඊට පස්සේ පැය දෙකක් glucose දීලා බලන එකනේ. So it's usually in the morning, but when you are doing the proper OGTT, then the time is not a problem, but otherwise it changes. So therefore you can't rely on the measurement levels. Right. So these are some of the drugs that we use. පොඩක් ඇහැට හුරු කරගන්න. MCQ එකේ තියෙන octreotide is the treatment of choice නෙවෙයි. Surgery is the treatment of choice, but we sometimes use octreotide to shrink the tumor before surgery to make it more operable and also to reduce the complications. Right. So that is about acromegaly. මේවා අහනවා. හරිද? MCQ වලට නිතරම අහන areas මේවා. ඉතින් රෙයා වුණාට ඔය වගේව නිතරම අහනවා. Any questions on that one? Question number 3 is on acromegaly. Any questions on this?
So do macroadenomas only secrete growth hormone and prolactin?
No. So some macroadenomas are non-functional, right? And they can secrete various other hormones also, right?
Thank you.
Right. Right. Now we go to hyperprolactinemia. So there is increased prolactin. Hari. මෙතනත් මේ causes වගේක් දීලා තියෙනවා. ඒකෙත් මම table එකක් දීලා තියෙනවා. ඔය ඔක්කොම හරි. Right? All of this is right. Sorry. Hyper නෙවෙයි hypothyroidism නේ. Hypo. Right. Now, so hyperprolactinemia can be due to pituitary tumors, but it can be due to various other reasons, as you can see here, right? And the typical clinical manifestations of hyperprolactinemia are galactorrhea, right? But also it can cause fertility issues, menstrual cycle disturbances, right? Erectile dysfunction වගේ ප්‍රශ්නත් එන්න පුළුවන් because of hyperprolactinemia. Right. Right. Now, here we are talking about, in question number 5, we are talking about prolactinoma. So this is a tumor, pituitary tumor causing prolactin. Now, in general, prolactinomas can be micro or macroadenomas, right? Usually they are microadenomas, usually, right? Important point is prolactinomas are much more common in females, right? Much more common in females, but males have bigger tumors, right? So in general, prolactinomas are common in females, but males have bigger tumors, right? So there is a high incidence of prolactinomas. Make a haritama word kala naha, but essentially what the statement should be is males lage more prolactinomas are macroadenomas. Prolactinomas can increase in size during pregnancy and rarely undergo malignant change also. Rarely, commonly anyway, rarely, right? So rarely malignancy in the pulo. Right. Now, diagnosis is you can do the serum prolactin level to diagnose it, right? And then we follow this up with imaging, right? So do the prolactin level and follow up with imaging. මෙන්න මේක පොඩ්ඩක් දැනගන්න ඕනේ මේක මේ ඉඳලා හිටලා විභාගෙදිත් අහනවා මෙන්න මේ ටේබල් එකේ වගේ තියෙන එක the actual level of prolactin can indicate whether it's a tumor or whether it's due to some other cause කියන එක, right? So for example, if the prolactin level is more than 5,000, you have a very strong confidence that it is a macroprolactinoma, right? ඒ වගේම if the prolactin level is less than 1000 and the patient has manifestation, might be to a drug or some other cause. So, ඒක පොඩ්ඩක් මතක තියාගන්න එක හොඳයි. Right? So, the level of prolactin can indicate the etiology. Right? And bigger the tumor, higher the prolactin level, as you can see. So, 5000ට වැඩි නම් we know it's probably a macroadenoma. 2000 to 500 range, it is a microadenoma. Right? And if it's less than 1000, it is due to something else, some other cause, like a drug-induced hyperprolactinemia. Right. So diagnosis is with prolactin and then imaging. Right? And the level of prolactin can indicate the etiology. Right. Now, unlike acromegaly, in prolactinomas, the treatment is predominantly medical. Right? And they respond very nicely to medical management. Right? Respond. Drugs of choice are things like bromocriptine, dopamine. As you know, dopamine value, it inhibits the prolactin secretion. Right? Dopamine value, it inhibits the prolactin secretion. So, dopamine agonists like bromocriptine, cabergoline are commonly used. And so, medical management is the first choice of first-line therapy. But however, sometimes we need to do surgery, especially if they are not responding to medication. Right? If they are not responding to medication, then we do surgery. Also, sometimes if the tumor is causing pressure effects, again, we will do surgery. Right? Right? So, treatment refractoriness, big tumors, right, causing compression of surrounding structures, these are the indications for surgery. But first-line therapy is usually medical කියන එක තමයි මතක තියාගන්න ඕනේ. Right. So, high incidence of macrodermis in males, having prolactinomas, increased size during pregnancy, commonly undergo malignant change. Rarely they can undergo malignant change. Surgical removal is the preferred modality for management. We usually do medical management, that is the treatment of choice. Radiotherapy is rapidly effective. It doesn't respond very well to radiotherapy usually. Right. So that's about prolactinoma. And මේක චුට්ටක් මේ ගණන් ටික මතක තියාගන්න සමහරවිට ඕක අහලා තියෙන අහනවා. ඒක not very fair to ask, but I have seen people asking this. Right. Right. Any questions? All right. No questions. Move on to 4 then. So next question. Question number 6. So now we are moving into thyroid disorders. Sorry. Did somebody want to ask a question? No? Okay, fine. Right. So now we move on to thyroid disorders, and here this MCQ is focused on hypothyroidism. So we're just asking the causes of hypothyroidism. Right. So as you know, hypothyroidism can be primary hypothyroidism, where there is a failure in the gland, right? Or there can be secondary hypothyroidism, right? And secondary hypothyroidism is due to problems in the pituitary hypothalamic axis, right? So primary or secondary. Here I have given you a list of causes of primary hypothyroidism, right? ලොකු ලිස්ට් එකක් මෙතන තියෙනවා. again අර ඇහුරු කරගන්න මේවා ඉතින් අර මෙන්න මේ වගේ ප්‍රශ්නවලදී අහනවා. හරි. ඒතර මේකෙත් ඔක්කොම හරි. right? දන්න නැත්නම් ඔක්කොම හරි ගහන්න. මොකද ගොඩක් වෙලාවට එහෙම තමයි. හරි. ඉතින් හිතලා තමයි එකක් වරදින්න දෙන්නේ. So yes, these are the causes of hypothyroidism. Especially remember lithium වගේ දේවල් වලට hypothyroidism එන්න පුළුවන්. And sometimes we treat hyperthyroidism with lithium also sometimes, right? Because it is a very, very potent cause of hypothyroidism. May amiodarone can be අමුතු එකක්. Amiodarone වලට you can get hypothyroidism, but rarely can get hyperthyroidism also. The reason for ඒකේ iodine තියෙනවනේ. Sometimes it can incorporate into the gland and the patient can get hyperthyroid, right? අනිත් පැත්ත වෙන්නත් පුළුවන්, hypo වෙන්නත් පුළුවන්, right? So because it can cause various අමුතු ඒවා වෙනවා gland එකේ when you take amiodarone. So amiodarone is a cause of hyper as well as hypothyroidism. දෙකම වෙන්න පුළුවන්. Right. Right, and you have seen the sort of classical appearance of hypothyroidism, and you can see that with treatment, you can see the facial morphology changing in this picture very nicely. Right. Now, this is again a very famous MCQ, like acromegaly. I mean, systemic manifestations of hypothyroidism is something that you need to remember. Right? Right? Godak theorem. Cardiac, very famous thing is pericardial effusion. Pericardial effusion, but of course, remember in hypothyroidism, they can get bradycardia, that's a common thing. And rarely they get a cardiomyopathy as well. Right? Cardiomyopathy godak in hyperthyroidism, but even in hypothyroidism, you can get a cardiomyopathy. But pericardial effusion is the famous manifestation. Pericardial effusion in a mixed edema coma, right? So that's a very interesting manifestation. Right. Neurologically, right? They get, again, neurologically, they can get entrapment neuropathies, right? Myopathy, proximal myopathy, right? And all of you know this slow relaxing reflex business in hypothyroidism. Slow relaxing ankle reflexes. And they are MCQ will read when make this. They get a cerebral ataxia. So hypothyroidism is an important cause of reversible cerebral ataxia. Right? So there are some special neurological syndromes that you get with hypothyroidism. Entrapment neuropathies, proximal myopathy, slow relaxing ankle jerks, this reversible cerebral ataxia. Right. And I've given you some other things to read as well. Right? Especially menorrhagia mataka tiyagana gene of salta bohom wadagat wen ekak hypothyroid related menorrhagia. When it comes so hypothyroidism can increase both the systolic and diastolic pressure. It is sort of a part of its metabolic action. Hypothyroidism, they get a metabolic syndrome with hypertension, cholesterol changes and things. As you can see in this slide, they get elevated cholesterol, triglycerides, right? And actually HDL that is also possible, right? HDL so low HDL is possible. And of course, you already know that you can get a macrocytic or normocytic anemia with hypothyroidism. Very severe anemia, but you can get a little bit of macrocytosis even in milder forms. Hyponatremia is very famous. You can get hyponatremia, right? Hyponatremia, right? And muscle involvement nisa CPK can go up as well. So these are common MCQ right? So these are some of your hypernatremia hyponatremia, right? And if we talk about this later on as well, it causes an SIADH like biochemistry. SIADH biochemistry in this hypothyroid induced hyponatremia, right? Right. Okay. Right. Any questions up to now? May hate mukut prashna tiyenawada? So both hyper and hypo causes proximal myopathy. Right. Now, how would you diagnose hypothyroidism? That is through the TSH. So the TSH is a very important thing. So of course you know that in a patient with primary hypothyroidism, the TSH will go up. So the primary nang TSH එක වැඩි වෙනවනේ. Right? But if the patient has secondary, that's pituitary problem, they will have features of hypothyroidism with a low TSH. So low TSH, if it's secondary because the pituitary is failing, then your TSH will be low, the patient will be hypothyroid. Okay. So that is how you diagnose it. TSH is very good to diagnose hypothyroidism. Of course, you do the thyroid hormones as well, but the TSH can be the first thing that you do, right? That is fine. True or false regarding the treatment of hypothyroidism? Replacement therapy with thyroxine is rarely lifelong. So the replacement, the management of hypothyroidism is with thyroid hormone replacement, and almost always this is lifelong. Right. The dose is usually 1.6 mics per kg. Dose එක අපි සාමාන්‍යයෙන් calculate කරන්නේ. Right. That is how you usually calculate the dose. And of course, important to remember that a patient with ischemic heart disease, you have to be very careful with their thyroxine doses. Because if you give too much too fast, they can have exacerbation of angina. Heart so you have to be careful. So start slow and increase slowly in patients with ischemic heart disease. Right? And the best thing to do is monitor their TSH, and that is a very good sensitive measure of your treatment effectiveness. Clinically, that is true, but the TSH will also help you to adjust your doses properly. Subclinical hypothyroidism කියන එක අංගර යකු note එකේ තියෙනවා. ඒක ටිකක් අමාරු concept එකක්. ඔයගොල්ලන්ට මම lectures වල ගන්නලා තියෙනවාද කියලා I don't think it's very important and undergraduate level. It's a very sort of controversial, not controversial, but endocrinology වල කතා කරන එකක්. ඒක වැඩි ඔයගොල්ලෝගෙන් අහන එකක් නෑ. හරි. Right. So higher initial doses vary. Ischemic heart disease, we start at a lower dose and increase, right? Very carefully and very careful. Hari. Right. Treatment monitoring, I told you, is best done with the TSH. That is the best way to do the treatment monitoring is with the TSH. Right. Now, usually, high dose are required in pregnancy is true. Usually, the treatment effect takes about 4 weeks විතර, 3 to 4 weeks විතර to start really kicking in, right? For you to see a response, it takes a little longer. සමහරට ඊටත් වැඩි වෙලා සති 6ක් වෙනකන් යන වෙලාවලු තියෙනවා, right? Because you need to establish that nice steady state of thyroxine that takes time, right? Sometimes it can take up to 6 weeks, but at least a month, 4 to 6 weeks යනවා for you to get the treatment in place and the effectiveness to start showing up. You definitely don't get any clinical improvement within 2 weeks, right? Up to 4 weeks to start getting a response, right? And that is because it takes time for the thyroxine to reach that nice steady state and will bring about a clinical effect. Right. So these are your treatment protocols, treatment principles, right? Right. Any questions about that? Hari. Okay. Right. Let's move on. So this is again what I have said. Right. And then we go to a myxedema coma ගැන කතා කරන්න. Before that, Hiran pericardial. So Hiran, the pathophysiology of pericardial effusions in hypothyroidism is complicated. There are several mechanisms that are proposed. One is people think there is increased capillary permeability. Also, make an albumin distribution volume එකේ චූටි වෙනසක් වෙනවා. Plus lymphatic drainage එක අඩු වෙනවා. Right. So there are several mechanisms there which are implicated. Hari? It's not very straightforward. Right. Okay. So myxedema coma, so this was talking about earlier, and that is very severe hypothyroidism, right? When they come with confusion, and sometimes they are in a coma, GCS adui. So myxedema coma, you can get hypoglycemia sometimes associated. You can get hypoglycemia, right? Hyponatremia is a feature. In severe hypothyroidism, they get hyponatremia, right? What do you do for treatment? right? Now, the problem here is that steroids you will of course give, right? And we talked about this before. So steroids then known, and you need to start the patient on IV hydrocortisone has a place in the management is true. Then of course getting the thyroid hormones into the system can be a bit challenging. So ඕක දෙන විදි තියෙන්නේ සාමාන්‍ය අපි NG එකක් දාලා you can give thyroid hormones, right? සාමාන්‍යයෙන් අපි දැන් guidelines වල කියනවා IV T3 වගේවා දෙන්න එපා කියලා කියනවා. හරි? That is sort of gone out of practice a bit, and we can use sort of NG thyroxine, T4, T3 to oral preparations වැඩි නැහැ, right? T4 loading doses දෙන්න පුළුවන්, right? So through the NG tube because they are unconscious, right? So these are some of the things that we do, right? මේක rapid කියන වචනේ කපා ගන්න අන්තිම එකේ rewarming is indicated කියන එක හරි. Right, so main things you do is warming. A rapid කියන වචනේ හරි නෑ ඒක කපා ගන්න. And then you give loading doses of T3 or T4 through the NG tube and also IV hydrocortisone. Usually, currently we don't give right. We usually don't give IV T3. Hari? IV T3 වැඩිය දෙන්නේ නැහැ. ඒක දැන් recommend කරන්නේ නැහැ. දෙන ඒවා ඔක්කොම එක්සිඩීම වල oral තමයි or NG තමයි දෙන්නේ කියලා කියන්නේ දැන්. Right. Okay. Any questions about question number 9 ළමයි? අෂ්ට මොන හරි තියෙනවද ඒක ගැන අහන්න?
Sir, one question about the previous question number 8. This in surgical ward, they do to monitor thyroxine therapy. They do this T4 actually.
ඒක වැරදි නේද? I don't know why they do that. TSH is supposed, and clinically also we know that TSH is the one that is more sensitive and changes earlier.
Right. Okay. No, what they say is minute titrate කරන්න ලේසි කියලා maybe.
Yeah, that is once you establish treatment, then there is a place there. Yes.
All right. Okay.
Yeah.
Okay.
එතකොට පොඩි then you have to look at everything, right? But otherwise, yeah.
Sure. Thank you.
Okay.
So in mixed edema coma also hydrocortisone before T3 then?
Oh, අපි ඒක තමයි ඉස්සෙල්ලා පටන් ගන්න. Yeah, okay. That is again because of the thing we discussed. නිමේෂ්ටත් එක්කම කියන්නේ ප්‍රශ්නයක් අහලා තියෙනවා. That is because you can never completely exclude the adrenal insufficiency also නේද? එතකොට ඒ නිසා තමයි අපි IV hydrocortisone දෙන්නේ. නැත්තම් ලෙඩේනේ. නේ? So you can never know that the patient comes in mixed edema coma where they have a concomitant adrenal problem also. So even though Nimesh, it can inhibit the peripheral conversion of T4 to T3, you're right, but still you don't know, so steroids will give that stress cover, right? When you're giving massive dose of thyroxine, it will give that stress cover. So that's the intention of giving steroids. So oral T3 කමක් නැහැ. Oral T3 දෙන්න පුළුවන්. NG එකෙන් තමයි දෙන්න ඕනේ. IV T3 තමයි දෙන්න එපා කියලා කියන්නේ. හරි? Yeah.
Excuse me, sir.
මේක හරි. Yes.
Sir, what happens to blood pressure in mixed edema?
Blood pressure depends. ගොඩක් අයට මුකුත් වෙන්නේ, but sometimes in very severe cases they can get hypotensive. හරි?
Hi, thank you.
Right, so that is about hypothyroidism. Okay. Right. Now, the free thyroxine, the problem is that you cannot always say that the patient is compliant to treatment also. Now, the importance of the TSH is, it is a good measure of thyroxine replacement, plus it gives a good idea of whether the patient is compliant to treatment. That's why it is the most useful to monitor. If you are using the free T4 levels, it will only say, okay, the other behet taragana. If you are measuring the T4 level, it takes T4 to yesterday, then the T4 will be normal. But the TSH will be abnormal. So it all depends on what your idea is, why you are monitoring the patient. The TSH is better reflective of the adequate replacement dose, right? And it also reflects whether the patient is compliant or not. The T4 leda thyroxine ගන්නෙම නැතුව ඉඳලා test එක කරන දවසකට කලින් thyroxine ගත්තොත් it can be normal, right? And you might be misled. So that is why I say the TSH is a better option, right? For monitoring, right? But of course, the thyroxine has an acute change. Free thyroxine, if you measure, it will measure the acute changes, but it's not necessarily going to reflect the proper state of your replacement or adequacy of your replacement. It doesn't take into account the compliance of the patient also. All right? Okay. Right. Hi. So, right. So, thyrotoxicosis. Now we move on to hyperthyroidism and thyrotoxicosis. Again, causes. All right? Causes. I told you amiodarone is a famous cause of hypo as well as hyperthyroidism, because the iodine component can get incorporated into the thyroid gland and that can produce more thyroxine. Right. Okay. Good. Now, thyrotoxicosis can be due to Graves' disease. There are other causes of thyrotoxicosis also, but Graves' disease is sort of autoimmune syndrome which causes thyrotoxicosis. Here, the pathogenesis is that there are thyroid receptor stimulating antibodies. So there are antibodies that stimulate the thyroid TSH receptor in the thyroid gland, right? So you are got TRABs, TRABs, thyroid receptor, TSH receptor stimulating antibodies, right? Now, patients with Graves' disease have certain unique features that you do not see in other causes of thyrotoxicosis. Of these, the classical ones are nail changes, like this is called thyroid acropathy. So they get nail changes, clubbing, and onycholysis, right? Onycholysis and clubbing. They also get the skin manifestations. It's called pretibial myxedema. Pretibial myxedema. This is clubbing. And also they get eye signs, right? They get eye signs, or this is called Graves' orbitopathy or Graves' ophthalmopathy. And these are supposed to be unique manifestations of Graves' disease, right? Which is an autoimmune disease. Right. So TSH receptor stimulating antibodies ane මේක පොඩ්ඩක් හදාගන්න stimulating කියලා sorry. ඒක හරිය. TSH receptor stimulating antibodies. That is the pathogenesis. That is the problem, right? Okay. And I told you that so uniqueness of Graves' disease is that there is thyroid acropathy, where there are nail changes, clubbing, onycholysis, right? There is pretibial myxedema, and there's Graves' ophthalmopathy or orbitopathy, eye signs, right? Because of Graves' disease. So pretibial myxedema is a feature, is right? So myxedema that doesn't mean hypothyroidism, right? In Graves' disease, you get pretibial myxedema, which is this rash sort of thing that I've shown in this picture on the lower right panel. Now, because Graves' disease is an autoimmune disease, it can coexist with other autoimmune diseases, right? Like pernicious anemia, right? And that is a well-known to coexist. You can get Graves with various other autoimmune disorders, myasthenia gravis and Graves' disease coming together. So it can coexist with other autoimmune diseases. Now, the unusual thing, and this frequently causes a lot of confusion, is that Graves' disease can also exist with Hashimoto's thyroiditis. And you can get, in Hashimoto's thyroiditis, you get this TPO antibodies, thyroid peroxidase antibodies. So sometimes you can get Graves with both of these antibodies, right? So you have thyroid receptor stimulating antibodies, or you have thyroid peroxidase antibodies, right? So both types of antibodies you can sometimes see in the same patient. And these patients can be euthyroid or sometimes hypothyroid. Graves disease, we see a small proportion of them who are actually hypothyroid as well, right? So that is another tricky MCQ point, right? Because of this Graves disease, you get a variety of autoantibodies. TSH receptor stimulating antibodies are the primary problem, but you can get sometimes coexistence of other antibodies like thyroid peroxidase, which causes hypothyroidism, right? So, ඒක පොඩ්ඩක් මතක තියාගන්න. හරි. Right. So TSH receptor stimulating antibodies are the primary causative pathogen antibodies, but you can get other antibodies like TPO antibodies are also circulating. When you make a MCQ point, where smoking has a strong predisposition to Graves' disease and actually worsens the eye signs. Right. Then we go to Graves' disease, the clinical and laboratory manifestations. Right, again, I have given you a list, right? I have given you a list of various manifestations. Right? So, alopecia, yes, can occur, right, in Graves' disease, and this might again be autoimmune, right? Some autoimmune alopecias in the Graves. AF is common in older patients, not in younger patients. AF is common in older patients. So, take a variety. Now, Graves' disease can cause a variety of funny things, right? Especially because the excess of thyroid hormones, a rare result of MCQ, unfortunately, it can cause increased bone resorption. මේ slide එක බලාගෙන යන්න ළමයි මේ වයින් ගොඩාක් ඉතින් MCQ high. හරිද? සාමාන්‍යයෙන් අපි අහන දේවල්නේ තමයි මේ කියන්නේ. හරි? Yeah. So you get increased bone resorption, hypercalcemia, hari මේ වගේ changes එන්න පුළුවන්. Right. Okay. So increased bone resorption, hypercalcemia. Right. Again, I have to emphasize මම විභාගෙට දෙන්නේ මොනවද කියලා දන්නේ නැහැ. දැනන්න ඕගොල්ලෝ මේ පන්ති කරන්නත් බෑ. මම ලීව් නිසා තමයි මේ පන්තිය මේ කාලෙදි කරන්න පුළුවන්. හරිද? මම දන්නේ මොන වෙනවද කියලා. but නිසා අපි ඉතින් ප්‍රශ්න හදන්නේ ඉතින් මේ වගේ දේවල් ඉතින් හැදෙනවා ඉතින් මිනිස්සු අති. හරිද? ඒවා ඉතින් ඕගොල්ලෝ නොකිය හංගල ඉඳලා තේරුමුකුත් නැහැ ඉතින් අන්තිමට මේ හංගල තේරු ගන්න. ඉතින් අහන ප්‍රශ්න අහනවා ඉතින් ඒක ඉතින්. Okay. So hypercalcemia, increased bone resorption is a feature. And මම අර කලිමුත් කිව්වා කවුරුහරි ප්‍රශ්නයකට අහුව ඕක සමල්කද කොහෙද? This both hypothyroidism and hyperthyroidism will known to cause proximal myopathy and paralysis. දෙකෙම එන්න පුළුවන් කියලා අපි කලින් කිව්වා. Right. තව famous එකක් තමයි ළමයි ඔයගොල්ලෝ දැනගන්න ඕන එකක් තමයි thyrotoxicosis වලට you can get a cholestatic type jaundice. Right. So it is again something that might be unfamiliar that is important to remember. Right. Thyrotoxicosis, Graves' disease. It is not unique to Graves' disease. It is a result of thyrotoxicosis. They can get cholestatic type jaundice. Cholestatic type jaundice එකක් එන්න පුළුවන්. Right. So hypercalcemia hari, hypokalemic periodic paralysis එක hari, elevated serum bilirubin එක hari. Right. So this is question number 12, which talks about the clinical manifestations of thyrotoxicosis. Right. Any questions about that one? Right. Okay, good. Now, this I told you was a import. So, ophthalmopathy or orbitopathy is a famous manifestation of Graves' disease, right? But can occur in the absence of other Graves' manifestations also. Right? මේක විතරක් වෙන්නත් පුළුවන් සමහර වෙලාවට. You can diagnose this clinically, but actually this is important. මේකත් important point එකක් ඔයගොල්ලෝ මතක තියාගන්න. You can get one of the earliest investigation findings is if you do an MRI scan, you can see enlargement of the extraocular muscles. Right? In Graves' orbitopathy, one of the early investigation findings would be enlargement of the extraocular muscles. Right? That is what you would see. Right? Right. So basically, hungry bone syndrome is something different. It is not due to thyrotoxicosis. It is due to something else, which I will describe later. හරි ඒකම පොඩ්ඩක් කියන්න. ඒක වෙන කතන්දරයක් එක එතන තියෙන්නේ, not thyroid. හරි. So hyperthyroidism interferes with the potassium balance in the body, and hypokalemia can cause paralysis. එතකොට ඒක එකට වගේ එන්නේ නිසා. Yeah, that is the mechanism. Right. So this we talked about, and here we go. Obviously, the established investigation is the thyroid function, right? And for Graves' disease, you would, if the facilities are available, you can do the TRAB, TSH receptor stimulating antibody එක කරන්න පුළුවන්, level එක බලන්නත් පුළුවන්, if you have the facilities. Right. Now, in general, lamai, the next question number 13, focuses on the management of Graves' disease. Right? Now, obviously, in Graves' disease, there are three management options. Right? There are three management options. Option number one is medical management with antithyroid drugs. That is option number one. Right? Medical management with antithyroid drugs. Right? And the second option is radiotherapy. Right? So the second option, management option is radiotherapy. Right? Radiotherapy means radioactive iodine therapy. Radioactive iodine therapy. Third option is surgery. So these are the three main management options for thyrotoxicosis, hyperthyroidism. Right? So either use medical management, antithyroid drugs, radioiodine therapy, or surgical therapy. Right? Most of the time, we start off by using drugs, medical management, and these are antithyroid drugs. Antithyroid drugs, commonly Sri Lanka will use two types. Right? Yeah. So yes, Sulakna, me samara thyroid gawita ka natuwa Graves' eye disease enda puluwa. Right? Yeah, it's funny thing that is. Okay. Right. So, so what are the antithyroid drugs? Carbimazole and propyltyrosol. These are the two ones that are commonly used in Sri Lanka, and of that, carbimazole is used a lot. Right. Now, the problem with carbimazole and propyltyrosol, any of these drugs, is that in order to get the treatment effect, it takes time. Right? Because at a high thyroid hormone level, to get back down to normal takes about 6 to 8 weeks, right? Because the half-life of thyroxine is about a week. So for the drugs to start working and to get all the levels down, it takes about 6 to 8 weeks for the therapy to become effective, right? So it takes time, 6 to 8 weeks. So because of this, we give beta blockers. In that interim period, a කාලිකම් bridge එකක් වගේ, we give beta blockers for symptomatic benefit. So our palpitation තිබ්බේම ඒවා නැති වෙලා යනවා when we give propranolol. Propranolol also has another effect where it can inhibit the conversion of T4 to T3. ඒක මතක තියාගන්න, right? Propranolol. So essentially, when you're going down the medical management part or medical management route, we use the antithyroid drugs commonly. And until you get the effect for about 6 to 8 weeks, propranolol is very, very useful. Right. And that is that. Carbimazole, propyltyrosol. Both of these drugs inhibit the synthesis of thyroid hormones, and also propyltyrosol additionally can inhibit the peripheral conversion of T4 to T3. Pharmacology. Now, what about so propranolol is a symptomatic benefit, right? Yeah, and also it inhibits the peripheral conversion of T4 to T3. That is another important point that you have to remember. Now, what about pregnancy and Graves' disease? The antithyroid drugs can be used in pregnancy. Dekama පාවිච්චි කරන්න පුළුවන්. So, but PTU is considered to be safer in pregnancy. Right? So, none of the drugs are absolutely contraindicated in pregnancy, but PTU is supposed to be a bit safer. Carbimazole causes a very rare fetal side effect called anaplasia cutis. Scalp formation එකේ ප්‍රශ්නයක් වෙනවා. ඒකත් ඔය MCQ ට අහන්න පුළුවන් එකක්. Right? Anaplasia cutis scalp formation එකේ ප්‍රශ්නයක් වෙන්න පුළුවන්. Carbimazole can be secreted in breast milk also. That is right. Contraindicated nè. Right. Now, an unusual phenomenon is that when you start the patient on antithyroid medication, it's well known that transiently thyroid eye disease can get worse. Right? Transiently, පොඩි කාලයකට thyroid eye disease can get worse. So that is an important point. ඒක මිනිස්සු හිතන්නේ because when you drop the thyroxine level, TSH එක කපාට චුට්ටක් වැඩි වෙනවනේ. හරි, TSH එක was suppressed. The TSH goes up a little bit and that can cause worsening of the thyroid eye disease. That's what people postulate as a mechanism, right? But again, there are lots of theories about that. But in clinical practice, we observe that when you knock off the thyroid hormones with the antithyroid drugs, transiently your thyroid eye disease can get worse. Right. Okay. Right. So medical management is structured in such a way that you give these drugs, carbimazole and propylthyrosol, takes about 6 to 8 weeks for the clinical effect, and you bridge that with the propranolol, which is an additional effect on T4 to T3 conversion. Right? And then you can get transient worsening of the eye signs while you're on treatment. Right? Radioactive iodine is also a commonly used thing, right? මෙතනත් මේ side effects ටිකක් anaplasia cutis එක ගැන කිව්වා, මේවා ගැන කිව්වා, මේ ඔක්කොම කිව්වා. Right. Now, radioactive iodine is also commonly used in managing Graves' disease. But the problem is that there is no standard method of calculating the dose. This is a common problem with radioactive iodine. එක මතක තියාගන්න ඕනේ, right? There is no way of calculating the dose. So they commonly become hypothyroid after you give them radioiodine. Hari? ඒක පොඩි ප්‍රශ්නයක් තියෙනවා. And also පටන් ගත්තම ගමන් මේ thyroid gland එක මැරෙනවනේ, radioactive iodine එක දීපු ගමන් thyroid cells මැරෙනවා. So අර ඇතුලේ තිබ්බ thyroxine ටික ඔක්කොම එකපාරට එළියට නිදහස් වෙනවා. Right? So the moment you give it, you can get a transient whether all the cells died, the thyroid cells, they die. So transiently it can cause worsening of hyperthyroidism. Right? So ඒක පොඩි ප්‍රශ්නයක්. And dose calculation එකක් නැත්නම් ඔක දීලා ටික කාලයක් යනකොට patient hypo වෙනවා ඊට පස්සේ. So ඒක හරි නේද? Initial worsening එකක් අපි observe කරනවා. That is true. Right. So that is question number 13. Any questions about that one?
Excuse me, sir.
Yes.
Or a radioiodine treatment, the patient should be euthyroid.
Yes.
Ideally.
Yes. And part of that is because that transient worsening, when you give the radioactive iodine, it sort of causes destruction of the thyroid cells, and that releases the thyroxine into the circulation. So ideally, you should be euthyroid before giving it. Otherwise, you're going to be getting into a big mess. Yeah.
ඒක අර එකක් තියෙනවා නේද efficacy එක වැඩි වෙනවා when the TSH level in your body is higher කියලා. ඒක නිසා
Yes, that's because it's incorporated better කියන. There is a theory like that. Yes.
එතකොට අර antithyroid medication කාලයක් නවත්තලා තියන්න ඕනද, like 1 or 2 weeks before the thing?
Oh, එහෙම කරනවා මිනිස්සු. Yes. There are various regimes that you do for that sort of thing. Yes.
All right. Thank
But those are a bit too advanced for you.
Okay.
Okay. Right. So make a question number 14 window. The 13 window. Right. So I told you that the two commonly used drugs are carbimazole and PTU. Right. So of them, the mechanism is very similar. Propylthyrosol can inhibit the peripheral conversion of T4 to T3. Right. Now, when you're monitoring Graves' disease, actually, අපි මේ ඔක්කොම බලන්න ඕනේ. Free T4, TSH, in order to get a better idea of how your treatment is responding, you have to look at the whole thing, especially the free T4, free T3, ඒවා බලලා තමයි අපි treatment adjust කරන්නේ. So TSH is useful, but the problem is TSH in a patient with hyperthyroidism takes a little bit of time to kick back up. Right? So you have to take everything into account here. Right? T4, T3, ඒවා ඔක්කොම බලන්න ඕනේ. Right. ඒතර useful නේ wording එච්චර හරි නෑ. ඒක නිකන් all වගේ දෙන එකක් වගේ නිකන්. දෙකම පාවිච්චි කරනවා කියන එක තමයි ඒගොල්ලෝ ඉගෙන ගන්න. Clinical benefit of anti-thyroid drugs apparently in 24 hours in a baila katawa. That's wrong because it takes about 6 to 8 weeks for the clinical benefit to be apparent. Right? So at least 4 weeks to start and the maximum effect around 6 to 8 weeks. Right. An important side effect of carbimazole is agranulocytosis. That is true. And we often do in the initial stages at least blood count monitoring. Right. Usually there is about a 30 to 50% relapse rate in patients on anti-thyroid drugs. That's a fact that you need to know. So usually there is a 30 to 50% remission rate. Right. Right. I think we stop here because this I need to explain a little bit more as well. Thyroid function test ගැන ඒක අපි කරමු. සමත් හෙට කොහොමද තත්ත්වය?
So හෙටත් මේ time එකට පුළුවන් sir.
පුළුවන් නේද? හරි. හෙට I will try my best to do it tomorrow unless I get pulled into some meeting tomorrow. And we can finish this and go into the next one as well. Hari? Yeah.
Okay.
Hi. Okay. මේක පොඩ්ඩක් මම පැහැදිලි කරන්න මට තව මීටින් එකක් තියෙන ඒක ඉවර කරගන්න බැරි වෙයි ඒ වෙලාව ඇතුළත පොඩ්ඩක් මේ 10 පාරක් කරනවා කියලා දෙන්න. හරි. Right. Okay. So today we have covered quite a lot, right? We have done pituitary problems, acromegaly, hypopituitarism, prolactinoma, thyroid, hypo and hyperthyroidism, right? So tomorrow we'll go on doing the other parts of this, which are adrenal තියෙනවා, හරි? And then move on to the other paper, which has I think diabetes තියෙන අනිත් එකේ. Yes. හරි? So ඒක කරගෙන යමු. We will try finish it off tomorrow. හරි? හෙට බැරිලකත් බැරි වුණොත් සිකුරාදට කරමු. හරි? මට පුළුවන් වෙයි බැරි වුණොත් සිකුරාදට කරමු.
Okay.
Hi. Right. Any questions in general about what we have discussed today?
Sir, what's the reason for anemia and thrombocytopenia in thyrotoxicosis?
Thrombocytopenia and anemia in thyrotoxicosis. One reason is that it can cause a sort of hemolysis. That is the cause of the anemia. So thyrotoxicosis can be associated with hemolytic anemia. And also immune thrombocytopenia. So that is sometimes what we see, right? I'm not sure whether it causes a bone marrow thing also, as far as I can remember. It does, right? But it can cause an immune-mediated destruction of platelets for sure, and hemoglobin, white red cells. So the remission rate is 30 to 50%. Yes, that's what I said. So relapse rate is 50% වෙන්න පුළුවන්. ඒක හරි. Is there any reason for growth hormone deficiency which come earlier than thyroid? I don't think there's any specific reason there, right? As far as I know, it's just a clinical pattern that we observe. Hi. Okay. හරි. සමත් වෙනම් මම ඔයාලට මෙසේජ් එකක් දාන්නම් හිට. දැනට පොඩ්ඩක් වෙලාව ෆ්‍රී තියාගන්න වෙලාව බැලුවම මම මෙසේජ් එකක් එවන්නම්.
හරි සර්. හරි. Thank you very much sir.
හරි. Okay.
Thank you, sir.